This is Unit 6A, Alterations in Gastrointestinal Function. It's pretty basic, so I'm going to try and be as quick as possible for you guys. On page 461 in the book, there are normal electrolyte values, so you might want to be able to just recognize normal, like potassium and sodium and calcium and etc. All right, so fluid differences in children. They have a larger proportional weight of the brain and skin, so they have more extracellular fluid. That's really important for the children because they have more extracellular space than you and I have. So if you're dehydrated, you lose extracellular fluid first, which is why it's so much easier for children to get dehydrated and why they get dehydrated so much quicker, because they have more extracellular fluid. Their kidneys cannot fully conserve fluid and electrolytes until they're 2 years old. And so they need more fluids in general, and they can only excrete but so much sodium. And proportionally, they have a higher water content. You can read those, you don't need to memorize them. They also have a bigger body surface area in relation to the body mass. So they have a greater potential for fluid loss via the skin. For example, if you have a newborn baby who's suffering with jaundice and they're under the Billy lights, they're going to lose more fluids due to those lights because they are losing fluid through their skin and through that greater body surface area. So obviously, if you've got a jaundiced baby under the lights, they're going to be needing to get some more hydration. So threats to fluid imbalance or fluid balance, they have a high metabolic rate, children do, especially if they're sick. And then they have less interstitial fluid reserve. Sorry, which means that they're at an increased risk for an imbalance. Stressors in children, they can include disease, like we just talked about, illness, exercise in hot weather, immature kidneys because they can't concentrate that urine. Their stomach can only hold but so much, and so they have a higher rate of peristalsis. And then they also can't communicate that they're thirsty to us. And so, how do you and I compensate if we're getting dehydrated or don't have enough fluid? We're going to drink. Well, they can't communicate that to us. And so that compensation is gone for them. Again, the stressors may create decreased fluid intake. So think if the stressor is that they're sick and they have RSV. Well, they're not going to be able to, they're not taking as much in. And then, or if they have a kidney problem or a heart problem and they're retaining fluid, then it's going to throw off the balance. And then if they have electrolyte loss or retention, they're going to have hypokalemia, and hypernatremia is the most common. Like I just said, the most common is the potassium. Your potassium is going to be low. So a lot of times in the ER, when kids come in with vomiting and diarrhea, we will check their electrolytes, get a basic metabolic, and we'll see what their potassium is on whether or not they need more boluses or possibly, if it's low enough, admission for dehydration. So medical treatments that can actually affect or cause fluid imbalance. NPO orders, like an NPO, if I don't drink anything after midnight for myself, that's fine. But for a little infant, that obviously is not going to be okay, and they would need to come into the hospital if they were going to be NPO after midnight. Think about people who are getting IV fluids. Are they incorrectly ordered? Are they getting too much? Are they getting too little? Drainage, for example, if we've got a Salem sump to suction, how much is draining out of that? Or if they've got a chest tube, how much is coming out of that? if they've got a lot of bleeding, or if they've got, or again, if they're fluid errors. Diuretics can also cause electrolyte imbalance. All right, so dehydration is a critical condition that's a result of extracellular fluid loss. And we talked about how, again, children have more extracellular space, and so they're more likely to get dehydrated. And there are 3 types of dehydration. I'm going to go over all of them briefly. You don't need to memorize them, but it's good to know what each 3 of them mean. And actually, somebody who's dehydrated can go through all 3 times, because your body shifts fluid around to try and compensate for it. And so you're actually going to go, through different types of dehydration. And the way to differentiate the dehydration is solely on the sodium level. So isotonic is the most common. This is what you see with the norovirus. It's where water and electrolytes are lost in the same proportion, and your serum sodium remains within the normal range, so 135 to 145. So majority of the fluid comes from the extracellular spaces, and it can result in hypovolemic shock, again, usually due to vomiting and diarrhea. Hypotonic, you are losing electrolytes or sodium quicker than you are losing fluid. So your sodium is going to get low, so less than 130. It is going, your extracellular fluid's going into your intracellular fluid, into the intracellular space, so the intracellular fluid is more concentrated. And this can also result in shock if untreated, and can be caused by water intoxication. So think about those football players, in August, outside playing in 110-degree weather with full pads on, and all they're drinking is water, and they're not drinking any Gatorade or replenishing any of those electrolytes. They can get water intoxication. Severe and prolonged vomiting and diarrhea. So this is going to be something more severe than just a norovirus, probably. Burns, you lose a lot of fluid in burns. Renal disease, or if you're getting IV fluids without electrolytes and you need those electrolytes. So hypertonic dehydration is when the loss of water is greater than the loss of the electrolytes or the sodium, so your sodium is going to be high, so more than 150. It is the most dangerous one. And so your body compensates by pulling water from the intracellular space to the intravascular compartment. And the reason it's the most dangerous is because the extracellular space appears normal. And so you may be getting more and more and more dehydrated, but since it appears normal, we're not doing anything. And then all of a sudden you're seizing because your sodium is so high. So they may have moist mucous membranes, they may be creating tears, they may be peeing, and all of that until they're not, and then they're seizing. So this ends up with neuro symptoms. This can be a result of diabetes insipidus or IV fluids or tube feedings with too high of electrolytes. So causes of dehydration, we've gone over a bunch of them already, but vomiting, diarrhea, GI disorders, so pyloric stenosis, malabsorption, we'll go over those in a little bit. Hemorrhage, if you're NPO, you've got Salem sump, hook to suction, fever, especially in those little ones, again, that greater body surface area. Burns we talked about, renal failure, all of these are causes of dehydration. So clinical manifestations, there is a table in your book, and I will put it on Blackboard, that goes over mild to moderate to severe, and it's on page 410. It's a really good thing that you should know. You should be able to differentiate between mild and moderate dehydration. Those are usually grouped together as opposed to severe. So decreased skin turgor, they're going to lose weight, they're going to have dry skin and mucous membranes, they're not going to be putting as much urine out. They may have thirst. If they're an infant, their fontanelle may be sunken in. Rapid pulse and rapid respiratory rates, probably a late sign. You can also think about blood pressure. If you take it while they're supine, so they're laying flat, and take their blood pressure and then have them either sitting up with their feet dangling or then standing. The standing or the one where they're sitting up, if that is less than the one where they're lying flat, then they may be dehydrated. That's called orthostatic. So that's another way to assess for it. Their temperature, their body skin might be cold. Their body temperature, they may be afebrile to febrile. If the reason that they are having dehydration is infectious, they're probably going to have a fever. They're not going to have any tears. They're going to have sunken eyeballs. Lethargic is also a late sign. So what are we going to do? So obviously, we are going to correct the fluid and electrolyte imbalance, and we are going to treat the underlying cause if we can. If it's something that's viral, like the norovirus, we're just going to support them, but correct that fluid and electrolyte imbalance. The initial treatment, the oral rehydration therapy guidelines are on page 414. Like I said, mild to moderate, you're going to do oral. You're going to start with Pedialyte. You want to start with Pedialyte as soon as you can, and you want to educate parents on this, that as soon as if they have like one episode of diarrhea or vomiting, as soon as you want to start that as soon as you can to hopefully prevent them from becoming severely dehydrated and prevent them from needing an IV and possibly a hospital admission. So just so you know, for purposes of the NCLEX, in the NCLEX hospital, you are only going to give Pedialyte or oral rehydration. There's some mixed opinions out there about Gatorade, because Gatorade does have electrolytes, but it's also extremely high in sugar and calories, and even the low sugar ones are still pretty high, and that high sugar content can actually cause diarrhea, so it may make the problem worse. So again, in the NCLEX hospital, just Pedialyte. We're going to do IV fluids if they are severely dehydrated. You will have to know, this is important, how to calculate maintenance fluids. And on page 415 is the formula. And again, I will put that up on Blackboard. And then I'll also do some sample problems, just remind me in class. But you will have to know for test 3 how to calculate maintenance fluids. Also, before you give IV fluids, at least with potassium, it is really important to know what their baseline kidney function is. So if they are not peeing, are they not peeing because they're dehydrated, or are they not peeing because their kidneys aren't working? Which I've talked about this in other areas that we've covered. But again, you want to establish kidney function before you add potassium to those fluids. So you're probably going to start with just a normal saline bolus of 20 mLs per kilogram, and you can do up to 3 in the ER. And then you'll probably go to replacing that fluid more gradually with maintenance fluids over the next 24 hours, which is, again, why we need to learn how to calculate maintenance fluids. It's based on weight. So as a nurse, you're going to be continuously assessing for signs of dehydration in these children. You're going to weigh the child, especially the young ones. That is, to know how much to give the bolus. That should really be a priority, honestly, is to know, you have to know the weight in order to know how much fluid you're going to give them. And then you want to know if they are gaining any weight while they're in the hospital to know that they're getting rehydrated properly. Obviously, you're going to monitor the I's and O's like we do on everybody. Weigh those diapers. You're going to do a physical assessment, look for skin turgor. You're going to look at those vital signs. Are they tachycardic? Are they tachypnic? These are the minimum urine outputs for children based on their weights. You're obviously going to encourage oral fluids as much as possible. So their favorite fluids, and you're going to want to do small amounts frequently so as not to overwhelm their stomach. You know, if you overwhelm their stomach and they drink a ton, then they're probably going to vomit it back up because they're just not used to it. So just do small amounts, you know, every 15 minutes or something like that. Use straws if they really like straws. Popsicles are a great way to get fluids into children. Applesauce, things like that. All right, so cleft lip and palate is pretty fascinating. I'm sure you've seen some crazy pictures. I have seen this both being repaired in the hospital and on some of my mission trips to Africa. Seen them in person. They obviously don't typically get fixed unless they are in a country that can do the surgery that's needed. So it's the most common of all facial anomalies in children. It is cleft lip is obviously an incomplete fusion of the lip, and the cleft palate is the incomplete fusion of the palate. You don't need to know about when it develops. We typically like to fix these early to prevent the things that they are prone to, so to prevent dental deformities, recurrent otitis media, hearing loss, speech problems. So we want to fix it early enough to prevent those things. Cleft lip can really be mild to severe. It can be unilateral. It can be bilateral. It can occur with the cleft palate as well. So what's important is you want to see if they can even take anything by mouth. So, you know, typically the surgical repair is done within this first 6 months of life. And again, it may require several surgeries. But if they can't take anything orally, like if they cannot form a seal for breast or bottle feeding, they're going to get that surgery done earlier than 6 months of life. It's going to be, you know, kind of a stat thing. However, if they can form a good enough seal to get most of the breast milk or most of the bottle, then you can wait a little while. And they do have special nipples for these babies. So pre-op care, you're going to provide emotional support for the family. Obviously, this is not, you know, sometimes when they first come out, they can look kind of scary because it's not what the mom and the dad and the family all had pictured as the child looking like. So it is kind of a loss of what the perfect child, what they thought their child was going to look like. And again, like I said, they may or may not even be able to be fed by mouth at all until after surgery. So some of them may need tube feedings to get them to surgery, unless they want to do surgery earlier. So post-op care for cleft lip, elbow restraints. As much as we don't like to use restraints, you know, children want to put everything in their mouth. And so to prevent that child from putting their fingers and whatever else they can get their little hands on in their mouth. So you want to remove those restraints at least once per shift for range of motion, and obviously maintain a up-to-date order for the restraints. And then if a parent or nurse is in the room, it's okay if the child with the child if they're not in the restraints. But, you know, educate that parent to let you know as soon as if they need to leave, or as soon as they need to leave, so that you can put the child back in restraints. And again, it may be several surgeries over several years, so it may be a a long course for these children and these parents. So lip care, you're going to clean the suture line. You're just going to clean that with some normal saline and maybe put some antibiotic ointment in there. You want them to be supine or sideline, obviously not prone. You never put kids prone anyways because of a risk of SIDS. But also you want to think about those incision sites, so you want them to be supine or sideline, so it decreases the risk of infection. Also, you're going to want to rinse their mouth out with water after eating, because if you think about it, breast milk and formula is going to be high in sugar, and that's just going to create a good environment for an infection to those suture lines. So you want to clean it with water to make sure that to help decrease that infection. All right, the cleft palate is an incomplete formation of the hard or soft palate. It can be unilateral or bilateral, and the repair is usually done by 18 months, but it depends on the severity. It's usually done by 18 months so that they can develop normal speech and won't have any speech impediments or anything for the rest of their life. This is usually checked for in the newborn nursery. You guys may have done it in maternity, but you can run your thumb or whatever in their mouth. Usually it is caught when they are feeding and breast milk or formula comes out of their nose. So if that happens, you want to make sure that they're still getting some of that breast milk or formula, and you want to make sure that they're peeing and getting some of that fluid in, and kind of assess how much is actually coming out of their nose. And then you'll just let the pediatrician know, or whoever, for follow-up. Again, I talked about early correction for development of speech. And this one may also be staged over several years. Post-op care is pretty much the same. You're going to use elbow restraints. You're going to use a syringe or cup feedings. With this one, however, you're going to avoid straws or utensils in the mouth to prevent damage to the incision site. And you're going to suction nares if you need to help to prevent infection. Again, you're going to want to have the head and the chest elevated. You're going to want them to take in high-calorie, soft foods. You're going to want to rinse with water after each feeding, like we talked about previously. Burp frequently, allow for more time for feedings, because now they're getting used to the feedings, and before they would need more time as well. And then watch for any signs of distress if the child vomits or anything like that. All right, so pyloric stenosis. So obviously the pylorus is the opening between the stomach and the duodenum. And what this is hypertrophy or overgrowth of the muscle of the pylorus. And this usually occurs between about 2 and 8 weeks of age, and it typically happens to the firstborn males, but typically males in general. There is a genetic component to this. And basically what it is so the infant begins with regurgitation, which is normal, and it's a small amount. And then as the pylorus becomes more and more hypertrophied, then they vomit more and more and more because it's not getting through that pylorus. And so then it eventually becomes projectile. I mean, like really vomiting across the room. And these infants, they are very fussy because they're not getting anything in, and they're not eating, and their emesis, they're not creating any bile. And then their emesis may be blood tinged due to that repeated esophageal irritation. So it's just being, it's repeatedly, the child's repeatedly vomiting and repeatedly coming back up. And so there may be some blood in that projectile vomiting. They're not going to be gaining weight because they're not getting anything in. They're not going to have any stools, obviously. They're going to be dehydrated, and they're going to have electrolyte imbalances that probably would reflect metabolic alkalosis. So the way that I remembered things in nursing was metabolic alkalosis for vomiting, because if you drink too much alcohol, you vomit. And then for diarrhea, which we'll get to later, metabolic acidosis, because diarrhea is coming out of your you-know-where. Okay, just my little sidebar, sorry. How to diagnose it. You're going to get a history on them. You're going to get a physical exam. You may get a small palpable mass in the right upper quadrant, which would be hard and olive shaped. But they're going to do an ultrasound. And you're obviously going to correct that acid-base imbalance, and we're going to go to surgery to correct this. So they're going to need IV fluids and potentially an NG tube. And so the surgical correction is called a pyloromyotomy, which is basically where they just go in and they cut the pylorus muscle. And they have this, these little boys have a great prognosis. So post-op, you're obviously going to be the same as any other GI. You're going to wait for bowel sounds to return, and then you're going to go clear to formula. So you're going to start with Pedialyte and then go to formula. You're going to watch that incision for signs and symptoms of infection. You may even have to fold down that diaper to avoid irritating that incision. So it is possible, again, you want to educate the family on this. It is possible for these babies to still have some regurgitation, but if they throw up 2 feedings, and I'm not just talking about, like have a little reflux with the feedings, but if they vomit all the feedings 2 times back to back, then they need to come back to the hospital because the surgery probably didn't work. They're typically not in the hospital long after surgery, and like I said, they have a great prognosis. So reflux, you guys know what GERD is. It tends to be very common in children, can be related to allergies. So you're going to want to do a history. Are they spitting up a lot? Are they not gaining weight? You're going to want to do a physical exam. You may do diagnostic testing. They probably aren't going to go through all of this, though. For the children, just to diagnose them with GERD, they're probably just going to do the history and physical exam. These children are at risk for aspiration pneumonia, so you're going to want to watch their respiratory status as well and teach the family about watching out for respiratory status. You're going to want to do, and this is patient and family education, they're going to want to do small frequent feeding, so like every 2 hours as opposed to every 4 hours. This is a little controversial, but for GERD, it's okay to thicken the formula with cereal. And this is going to be only rice cereal, not wheat or white or anything else, just rice cereal. The reason it's controversial is because if you thicken a healthy kid's formula, then you're putting them at risk for aspiration. Well, these children are already at risk for aspiration, so you're not really increasing their risk. And I've heard some parents swear by it, that it helps them a lot to not regurgitate their formula. So again, it is okay in the NCLEX world to thicken formula with rice cereal if the child has GERD. You're going to want to burp them more frequently, obviously, and then you're going to want to feed them upright. You're also going to want their head of the bed elevated after the feeding. There is such a thing as a reflux sling to position after feeding as well. Like I said, you're going to want to assess that respiratory status and watch for any signs or symptoms of aspiration pneumonia. So a Nissen, we actually talked about this in the Friday clinical group. So they do this in children and adults. It's typically done with people who have CP or muscular dystrophy. But basically what it is they take the pylorus and wrap it around the end of the esophagus so that literally you cannot vomit, and you really can't even, the most you can do is gag, but because that reflux is still in place, but that vomiting and that reflux can't happen. So a lot of times they will do a G-tube, like a Mickey with a Nissen. And so that's important, and that is obviously something that we would do in severe cases of reflux, not in just your typical everyday reflux. Sorry, I had to take a sip of water. These are your medications to decrease acid. You guys have given these a million times. And this one for Reglan, if you want to think about it, you are accelerating that gastric emptying time, and so a side effect with that tends to be diarrhea. So you would want to watch hydration status with that. So intussusception is pretty interesting. What it is the intestine is actually telescoping into part of itself. And so it's common at the ileocecal valve area and pushing that into the cecum and the colon. Vascular blood flow is obstructed when this happens. And obviously the intestine becomes inflamed because it's telescoping and rubbing against itself. And so then it's inflamed, and then edema, and then it's going to bleed as well because it's irritated. Most commonly occurs in males from 3 months to 6 years of age. The cause is really unknown, and the onset is usually abrupt. They're gonna present with severe abdominal pain, abdominal distension. They're gonna have vomiting that looks like bowel. This is the hallmark sign, and this, if it's on NCLEX, this is gonna be on there. And so the way that so the hallmark sign is current jelly-like stools. So that means that there is like blood. Current means purple, red, mucousy stools, okay? And the way that I remembered this in nursing school was that there are 2 S's in intussusception, and then the 2 R's in the current jelly-like. So those 2 R's and those 2 S's go together, okay? So it's current jelly-like stool. And then you may find a sausage-shaped mass in the right upper quadrant. But again, that red blood and mucousy stool is just the hallmark sign. And if they have blood and mucus in their stool, they have intussusception. So you're going to want to get a history on the child when they come in. They may x-ray the abdomen, or they may go straight to ultrasound, and that locates where the intussusception is happening. And then they're going to do a barium or an air enema, and that is diagnostic, or it can actually fix it because it pushes the intestine back to normal from that air enema. And so you fix the problem by also diagnosing it. So we just talked about how to manage it with the enema. They also may do surgery. So they may do a reduction, or if a part of the bowel has died, they may do a resection. So again, post-operatively is going to be the same. You're going to want to wait till bowel sounds return, and then you're going to want to go to clear liquid, so Pedialyte, and then formula. You're going to want to teach the parents to look for passage of the normal stool, and that can indicate that the surgery was successful. So gastroenteritis or diarrhea, you guys all know what diarrhea is. Increase in the frequency, fluidity, and volume of stools. It can be acute, like with the norovirus, or it can be chronic. It can be due to inflammation or not. Like I already told you guys about My Little Way to Remember, they're going to be at risk for metabolic acidosis. Causes of diarrhea can be viral, bacterial, maybe have a parasite in there. With the norovirus, there's so many strains that our immune system just can't develop immunity to the norovirus, to all the different strains. So that's why, even though there is a vaccine and there, you probably had 8 different kinds of norovirus in your life, you're still going to continue to get the norovirus. Medications like chemo, foods or emotional stress, malabsorption, we're going to talk about in a little bit, colon disease, IBS or irritable bowel syndrome, intestinal obstruction where the stool is just going around that impaction, but is, there's still an obstruction in there. So obviously you're going to have an increased amount of stools. They're going to be liquidy. You're going to be irritable. You might not feel like eating or drinking. You're going to have nausea and vomiting. You're going to have cramps. So just like with dehydration, mild to moderate diarrhea, you're going to want to do oral rehydration. And again, it's important to begin within as soon as possible, but especially within the first 24 hours of the illness. Pedialyte is good for children, and you can also educate them on diluting the breast milk or the formula. It's very important, though, you're not diluting it with water. For infants, you're diluting it with half formula, half Pedialyte to get some of those electrolytes back that they're losing through the diarrhea. You're going to want to avoid liquids or foods that are high in carbs, sugar, fat, caffeine. So we talked about Gatorade earlier, so that would be on there. Avoid carbonated beverages. Again, that's kind of a personal preference if they want the bubbles or not. And avoid cow's milk because it irritates that GI system until the diarrhea resolves. So there are a couple diets that help with diarrhea. It depends on age, preference, really, and hospital and doctor. Probably the one you've heard of the most is probably the BRAT diet, so bananas, rice, applesauce, toast. These are okay in the short term, but they are not appropriate for chronic diarrhea because there's no protein in there whatsoever. So if they are taking in solid foods, you can do these as well. If it, again, just like dehydration, if it's severe diarrhea, we're going to do IV fluid. Again, we'll probably do a bolus. And again, a priority nursing intervention would be knowing the weight so we can know how much to give them for the bolus. And to know if they're gaining weight. You're going to want to treat the cause of the diarrhea if you can. Obviously, if it's a virus, you can't do anything. But if it's a parasite, you can get rid of that parasite. Promote rest and comfort. For the little ones, you want to worry about, and for the adults, but more so the little ones, you want to worry about skin care. With those diapers, their poor little heinies just become so raw. From the diarrhea, and so honestly most of the time you just kind of abandon the wipes and use as soft of whatever you can find and just use mild soap and water because the wipes can further irritate it and just hurt it even more. Again, constipation, you guys all know what that is. The third one would be like if they were impacted, they're gonna, they may have that liquidy stool go around it. It peaks at age 2 to 4 years because that is when they are being potty trained. And also, it's when they're really developmentally can be picky eaters. So if they don't want to eat their vegetables or fruits, they're going to be constipated. They're also, again, just aside from being a picky eater, there are other causes like hypothyroidism, hypercalcemia. We've talked about lead and iron before, spinal cord lesions, excessive milk intake. Also, like an underlying disease, something like a germ cell tumor or something like that may first manifest itself as constipation. Diet, psych, if I could only tell you how many of our constipation admissions I think have psychological components. It would be a very interesting study because I do think there is a psychological factor to constipation. If they have like a structural anomaly, dehydration, lack of exercise. So how are we going to manage it? Obviously, you want to hopefully manage it outpatient. And so increase the fiber in their diet, so fruits, vegetables, whole grains. You're going to increase the fluid intake, water preferably. Remove constipating foods from their diet. Again, this can be tough if they're picky eaters. Exercise is really important to get that peristalsis going. They may be on a stool softener or Miralax or whatever works for them. A glycerin suppository, enemas, behavioral conditioning if there's a psych component. The most important thing is once you get, like if they, are really constipated or impacted, once you get them disimpacted and not constipated, they need to be on a bowel regimen because they need to be on something that is continuously working on it to prevent admissions. Their bowel regimen may just be a daily stool softener, and that's good enough for some people. And other people may require, a stool softener twice a day and Miralax and something else. It just depends. They need to figure out what bowel regimen they need and they need to stick to it. All right, so malabsorption syndrome is the inability of the body to absorb nutrients. And an example would be like celiac disease or lactose intolerance or necrotizing enterocolitis, which is actually where part of the bowel dies off. It is the leading cause of death in the NICU, and it's called NEC, and NEC leads to short bowel syndrome, obviously, because they're going to take out the part of the bowel that's died, and so then your bowel is now short. So they weren't very clever in that name, but it leads to short bowel syndrome. So it is an acquired malabsorption syndrome. It occurs after a massive resection of the small intestine, so about 25% or more. Again, more commonly occurs in premature infants, and it leads to a decreased ability to digest and absorb regular diet because of the shortened intestine. So these children may be on TPN and lipids for the rest of their lives, unfortunately. Or they may be able to absorb enough that they can just do G-tube feedings. It all depends on what their body can and cannot absorb. So they're probably, if they have a central line or, even if they have a G-tube, you're going to want to think about preventing infection is important. So hand washing and looking at that dressing and changing the dressing when needed, and sterility when you're accessing that central line and all of that. Diarrhea can also be a potential complication. So dumping syndrome, that obviously can affect electrolytes if they are just having diarrhea. It can lead to a developmental delay. If you think about it, eating is a very social event. It's a social thing for most people. And so if they can't eat, it may lead to a developmental delay because they're not spending that time with their friends eating. They may also have oral avoidance. So weight is important on these children, and they may be on GI meds for the rest of their life, like Pepcid and stuff like that as well. All right, so that is it for GI. Let me know if you guys have any questions.